The topic of today is traumatic injuries. Every now and then, here and there, we hear about accidents on the street or inside the house. Now, these accidents lead to trauma. What is trauma? Trauma is basically any injury which is a result of external violence or accidents. It leads to degeneration and fracture. And what is fracture? Fracture is any discontinuity which is brought about in the surface or the epithelium, which may be either complete or it may be incomplete. Traumatology is the study of the trauma and study of fracture and wounds basically. So, there are various classifications based on the clarity and the ease of representation of the fracture, the degree of trauma to a particular place or a particular object. For example, a tooth. So, Ellis and Davy in the year 1960 had put forward a classification of fracture of anterior teeth, which involves 9 classes. Class 1 involves simple fracture of teeth involving only enamel, and it's basically an uncomplicated fracture. It does not require or has involvement of dentine or pulp. Now, class 2 is the extensive fracture of the crown, which involves enamel as well as dentine. Class 3 involves the exposure of dental pulp involving enamel, dentine and dental pulp. Class 4 belongs to traumatized teeth which becomes non-vital or the pulp becomes degenerated due to trauma. That is the fracture involving enamel, dentine and pulp. The class 5 type of fracture involves the tooth which is lost as a result of trauma or fracture, or basically avulsion or extraarticulation of the tooth. Class 6 involves the root with or without fracture or loss of crown. It is basically fracture of root. Class 7 is the displacement of the tooth from the axis of the tooth, or it is subluxation of the tooth. And class 8 is fracture of crown and mass. That is, it is a fracture of entire crown or the entire crown is lost. And class 9 belongs to injuries of primary teeth. Here we can see a picture which is representing class 1 to class 8 type of fracture. Number 1 represents fracture of enamel, that is class 1. Class 2 is fracture of enamel and dentine, which is represented by a blue circle. Class 3 is fracture of enamel, dentine with exposure of dental pulp. Then class 4, the blue area represents that the tooth has become non-vital or the pulp is degenerated. And class 5 is loss of tooth as a result of injury, that is avulsion of the tooth out of the socket. Class 6 is slide, it is fracture of the root and displacement of the tooth. Class 7 is the displacement of the tooth from its axis. Class 8 is the fracture of crown and mass, which is represented by a blue circle, that is fracture of entire crown. And class 9, as we have already known, it belongs to fracture of the primary teeth. There was another classification which was put forward by MacDonald, Avery and Lynch. They modified the Ellis classification into just 4 classes. Class 1 involving enamel, class 2 involving enamel and dentine, then class 3 involving enamel, dentine and exposing the dental pulp, and class 4 is the loss of entire crown. Now, another famous classification was put forward by Anderson in the year 1981, which was later modified by WHO. Anderson classified the traumatic injuries of anterior teeth as the trauma to the hard tissues, that's trauma to the tooth, and the other type belongs to trauma to the gingival tissues or the supporting tissues of the tooth, that is the periodontium, then trauma to the alveolar bone, and finally trauma to the soft tissues. These four classes had further subclasses. The injuries to the hard dental tissues involved crown infarction, which is also represented as numeric like N873.60 and further on. So what basically is crown infarction? Crown infarction is a craze or a slight hairline fracture in the crown. That is, in the crown of the anterior teeth have a slight fracture due to a blow injury. It is an incomplete fracture of the crown. It basically involves enamel only. Then class N873.70 involves uncomplicated crown fracture. That is, it is contained to the enamel and the dentine without involving the dental pulp or exposing the dental pulp. Then comes complicated crown fracture, which is N783.62. It involves enamel, dentine and exposing the dental pulp. That is why it is called the complicated crown fracture. Then comes the uncomplicated crown and root fracture, which belongs to the N873.64 class. So, it involves the enamel, the dentine and the cementum of the root, but not involving the dental pulp. That is, it is a fracture line that goes through the enamel, the dentine and the cementum of the root. Further comes the complicated crown root fracture, which involves enamel, dentine, pulp and cementum. That is, the root is also involved, but the pulp exposure is also there. Then comes the root fracture, which involves fracture of the entire root, that is involving the enamel, the dentine, cementum and the pulp. Here are the following photographs which represent the fracture which I have already explained. A is the crown infarction, then B is the uncomplicated crown fracture, C is the uncomplicated crown fracture involving enamel and dentine, D is a complicated crown fracture involving enamel, dentine and dental pulp, E is the uncomplicated crown root fracture which involves the enamel, the dentine and the cementum. Then F is the complicated crown root fracture involving the enamel, the dentine, the cementum and the dental pulp. And G is the root fracture. Now coming over to the injuries of the supporting tissues of the tooth, that is the periodontal ligament. It involves concussion. Now concussion is basically the injury to the periodontal ligament without any loosening of the support of the tooth. Then comes subluxation, that is, there is loosening of the tooth but there is no displacement of the tooth from the socket. That is, the tooth is not shifted from its axial line, but it cannot be neglected that the tooth is abnormally loosened in the socket. Then comes intrusive luxation, that is intrusion. It is the pushing of the tooth inside the alveolar socket due to loosening and displacement. Then extrusive luxation is the pushing of the tooth slightly out of the socket. That means loosening and the displacement of the tooth out of the socket along its axial direction. Then is the lateral luxation, that is the loosening or the displacement of the tooth laterally. And finally exarticulation or avulsion, that is a complete loss of the tooth from the socket. These are the following photographs which represents A is the abnormal loosening is not there, in B slight loosening is there or luxation is there, C is concussion, and D finally E, F, G and H represents further avulsion of the tooth out of the socket. Then injuries to the supporting bone, that is, the bone gets injured as a result of the traumatic injury. First is commitation, or it is a crushing injury. the alveolar socket is crushed as a result of the trauma or the impact. Then is the fracture of the alveolar wall, that is either labial or lingual wall gets destructed as a result of external trauma or external force. Then is the fracture of the alveolar process, that is a process which holds the teeth inside the socket, that is the alveolar process gets destroyed, the entire alveolar process gets destroyed. Then finally is a fracture of maxilla or the mandible, that is the jaw, either the maxilla or the mandible gets destroyed due to a crushing injury. These are the following photographs which represents the commitation of the alveolar socket, that is A. B is the fracture of the labial wall of the alveolar socket. C is the fracture of the lingual wall of the alveolar socket. D is the fracture of the entire alveolar process. And G is a fracture of the maxilla or the mandible. Then comes injury to the gingiva mucosa. It is further divided into either laceration, then abrasion and contusion. Laceration basically is a deep or a shallow wound in the surface or in the mucosa. It involves rubbed surfaces and is deeper than abrasion. Laceration is brought about by an injury through a sharp object. Then abrasion. Abrasion means the diminution of the superficial layers of the mucosa. It is a superficial wound than the laceration, and it is brought about due to frictional injury. And contusion is a blunt injury or injury which is brought about by a blunt object, which further leads to the internal hemorrhage, which may lead to bruises or break in the mucosa. Now there are various type of factors which are responsible for the injuries. These factors can bring about the injury. They may be the velocity of the object which impacts the particular teeth or the particular mucosa, the hard or the soft tissue. Then is the resilience of the object which impacts the mucosa or the tissue. Then is the shape of the object which is impacting. Then greater the velocity, greater the damage will be caused in the hard tissues of the oral cavity, that it will lead to either class 1, class 2, class 3 or class 4 type of fractures in the anterior teeth. If the velocity is less, for example, if a tooth is striking against a stable object, for example ground, it will lead to concussion or subluxation or the injuries of the soft tissues of the oral cavity. Now, if the object is more resilient, less injury will be caused due to the tooth, that is either the soft tissue or the hard tissue. It also is responsible the shape of the object, that is if the shape of the object is like it is sharp, then it will cause a sharp injury to the tooth, fracture to the tooth, either enamel, dentine or cementum, or the fracture of the root. If the injury is or the object is not sharp, it will cause a blunt injury and will lead to either bruising of the gingiva or the mucosal surfaces and soft tissue injury. So these are the factors which were responsible for the type of injury to the tooth. Even the direction of the impacting force is important. For example, if a force comes from a tangential direction, it will lead to complicated fracture of the crown and complicated fracture of the crown or the root. And if the injury is blunt, if it is brought along the long axis of the tooth, the fracture line will be vertical. It can also cause concussion or subluxation, even exarticulation of the tooth from its socket. Now, as the patient with fracture of trauma reports to our dental clinic, the first and the foremost, the most important crucial step is history taking of the patient. We'll ask the name, the age and other personal data of the patient. Then the most important thing is to record that how did the injury take place, when did the injury took place, and where and how did it actually took place. For example, that if the tooth is lost from the socket, we have to record the exact time when the tooth get lost. Then how did the injury took place, that is, if the injury is due to a fall from a bicycle or due to striking a hard object or due to any fight in the class or any accident. Then any history of previous injury should also kept in mind. There are certain anomalies like dentinogenesis imperfecta or epilepsy which may also make the patient more prone to injury. An epileptic fit may cause the injury if the patient is having dentinogenesis imperfecta. The teeth are lesser strong in nature, which will lead to more chronicity to the injuries. Now further, moving on to the clinical examination of the patient, we have to examine even the hard tissues and the soft tissues, the extraoral as well the intraoral examination of the patient. The extraoral signs of injury should be noted like swelling, any color change in the mucosa, any variation in the degree of the heat of the mucosa, whether the surface is warm or if the patient is having an elevated temperature, any fever or malaise, or any asymmetry in the facial profile, which will, if there is a fracture of the maxilla or the mandible or the jaws, it will lead to asymmetrical facial profile. Any injuries in the facial bones or the mandible should be palpated by the means of the gloves. We should take a note if there is any derangement of the occlusion of the patient. Each and every teeth should be examined whether there is any subluxation or concussion injury in the teeth, or maybe any crown infarction, or even complicated or uncomplicated crown or root fractures. Even the displacement and the subluxation injuries should be kept in mind and recorded one by one. Each and every quadrant-wise examination should be done so that there is no injury which is left over untreated and unexamined. So, if after recording all the history of the patient and making examinations of the extraoral and the intraoral part of the oral cavity, we further lead to investigations, that is the radiographic investigation of the patient, the pulp vitality test. The radiographic investigation of any teeth with injury should be recorded. It will help in assessing whether the teeth is vital or non-vital. Even the stage of the development of the root, which will further decide the treatment plan of the tooth, whether it will go for apexification or apexogenesis or pulpectomy or pulpotomy or even root canal treatment. The presence of any alveolar fracture or the presence of any root fracture can be ruled out from the same radiographs, and if there is any pre-existing periodontal anomaly or any pathological condition like periodontal abscess or gingival abscess, this can also be taken in consideration by the means of a radiograph. Generally, intraoral periocapical radiographs and occlusal radiographs are preferred in the cases of trauma. Now coming over to the pulp vitality test. There are different types of tests like the thermal test, which is a heat test. It involves placing of a hot gutta percha or a hot instrument on the buccal surface of the most prominent portion of the tooth, and the tooth is tested for the vitality, whether it is responding positively or negatively to the test. Then cold test is done by the means of carbon dioxide snow, dry ice or ethyl chloride, which will lead to the tooth, if it is responding, it will lead to positive test, and if it is not responding, it is a negative test. Even electric pulp tester is used for the vitality of the tooth, and all the documentation should be done regarding which tooth is vital and which tooth is not vital. and which will further lead to planning the treatment of the tooth. Now coming over to the individual treatment plan of class 1, class 2, class 3, class 4 complicated or uncomplicated crown and root fractures. We'll be discussing it individually. First, coming over to the enamel fracture. Enamel fracture is a class 1 type of fracture in which only a part of the enamel, there is either chipping of the enamel or the part of the enamel is lost. There is no loss to the dentine or the dental pulp or any of the structures of the tooth. Even the supporting structures are intact. The main management of enamel fractures is depending on the loss of the enamel structure. For example, if there is only chipping of the enamel, we smooth the edges of the lost enamel by the means of discs, and then further by the means of a straight fissure burr we recontour the enamel and we blunt all the positive line angles and point angles are there, and by the means of a composite resin or a glass ionomer cement we finally restore the tooth and make it look close to the aesthetic enamel. If there is a loss of the enamel is more or a major part of the structure of enamel is lost, we go for reattachment of the lost fragment. For example, if the patient brings lost fragment, we can reattach it to the enamel by the means of composite resin. Even temporary crowns can be given in the place of enamel, like porcelain fused to metal, or even veneers can be placed for aesthetic results. The frequency or the incidence of enamel injuries is more in 8 to 11 years of age of patient or children, or even the toddlers who crawl on the floor. They are more prone to injuries and fracture of enamel. A fracture of enamel is one of the most uncomplicated fracture to manage, and as I have already told, can be managed by the means of composite resin or just recontouring of the enamel. Then comes complicated fracture or enamel and dentine fracture. Class 2 type of fracture, the fracture which involves both enamel or slightly or a part of dentine but without exposing the dental pulp. Even a millimeter square of dentine, if it is exposed, it will lead to the exposure of about 20 to 40,000 of dentinal tubules, which means sensitivity. That is, as the dentinal tubules are exposed, the tooth will be more sensitive and it will be more prone to pain from hard or hot and cold fluids. So these open dentinal tubules which are responsible for this sensitivity. So basically the sensitivity depends on the amount of the dentine loss, that is the number of the dentinal tubules exposed, the thickness of the dentine which is already present over protecting the dental pulp, and whether the dentinal tubules are closer to the pulp or they are farther away from the pulp. Now how we will recognize that is the dentine is exposed? If the patient is having a minor pain or sensitivity on fracture and pain on mastication, then finally the confirmatory diagnosis can be made with the help of periapical radiographs and thermal sensitivity. Now how can we manage the patient with class 2 type of fracture? Basically, the application of hard setting calcium hydroxide is done, that is, the powdered form of calcium hydroxide or a dical is mixed with saline or the liquid available with calcium hydroxide, or if two tube system is available, the base paste and the catalyst paste are both mixed by the means of a small instrument or the ball burnisher on a paper pad, and it is finally placed over the exposed dentine surface. This will set immediately, even a second or 20 to 30 seconds are required for the setting time. Then restoration with the means of composite resin, and fragment reattachment is done finally for the same. Now coming over to the complicated crown root fracture, that is fracture of the enamel dentine with exposing the dental pulp. This is one of the most complicated form of fracture which involves a wide array of treatment depending on the factors which involve the treatment process. The basic factors are whether the tooth is vital or non-vital, the time which is elapsed as the tooth or the trauma is reported to the dental clinic, whether it is reported immediately or after a large span of time, after 24 hours, 6 hours, 12 hours, etc. The degree of root maturation, whether the tooth is having blunderbuss canals or the apex is closed or the apex is open. Then if the crown of the tooth is restorable or it is non-restorable. If it is non-restorable, it cannot be treated by any pulp therapy procedures, but the final outcome of the tooth is extraction because it has a poor prognosis. Then the aim of the pulp therapy procedure is to protect the dental pulp, the vitality of the dental pulp by using pulp protective measures. Various treatment options are direct pulp capping, pulpotomy, pulpectomy, and apexification. Now, what are the various types that when each procedure should be performed? Direct pulp capping should be performed when the inflammation of pulp is least or if there is immediate exposure of the pulp by a trauma or the patient is reported to the clinic immediately or on the spot of the trauma. If the smallest exposure of the site less than 1 millimeter square and 5 minutes of duration of time it is reported. If the tooth is not grossly contaminated, if the oozing out of blood is minimum from the site and there is a recent trauma. What is the procedure underlying it? The surface is washed by the means of a saline and the bleeding is stopped and the hard setting calcium hydroxide paste is adapted over the exposed surface. Finally, it is restored by zinc oxide eugenol, which is hard setting or zinc polycarboxylate cement, and the patient is recalled on the appointments of 2 weeks, 3 weeks, then a month, then 3 months, and so on. And finally, if on the radiograph a dentinal bridge is evaluated, we can lead to permanent restoration of the stain. The prognosis is 63 to 88% of the success rate. Now coming over, if the wound is exposed for more than 5 minutes or if the bleeding is moderate in grade and it is not easily stoppable on the spot, then we will go for pulpotomy. Even in the cases when the root is not completely formed or there are blunderbuss canal, pulpotomy can lead to apexigenesis of the root. So the underdeveloped apices who are having pulp exposure can be treated by the means of pulpotomy. And depending on the amount of exposure, it can be partial pulpotomy or complete pulpotomy. Partial pulpotomy is the removal of just the part of the dentine or the pulp which is affected and leaving the rest of the pulp. And complete pulpotomy is the entire extirpation of the pulp from the coronal pulp chamber. The procedure of pulpotomy involves local anesthesia, administration, then further by the means of a slow speed round burr extirpation of the entire coronal pulp or the part of the pulp which is inflamed or infected, then complete irrigation of all the pulpal debris out of the socket by the means of a sharp spoon excavator and irrigation by sodium hypochlorite and saline alternatively, so that all the debris and the pulp and the infection is flushed out. The wound is rinsed till the bleeding is stopped. Then a pellet of formicrosol is applied over the pulp stumps, and finally it is removed after 4 minutes and calcium hydroxide or zinc oxide eugenol is adapted in the coronal pulp chamber, which is further restored by the glass ionomer cement or a composite restoration. These are the following steps of the pulpotomy procedure, in which the entire coronal pulp is extirpated by the means of a slow speed round burr or a sharp spoon excavator, and over the pulp stone the cement, calcium hydroxide or zinc oxide eugenol is adapted and the entire coronal chamber is filled. The recall visits of pulpotomy should be on the duration of 2 weeks, then 1 month, 3 months, 6 months, 12 months, and so on. And it should be till 3 years. And the patient should be recalled and evaluated simultaneously. Then, if the bleeding does not stop, or if there is more than 60 minutes of pulpal exposure, or if the exposure is contaminated when no vital tissue remains in the pulp chamber and the root formation is complete, then we can go for pulpectomy. Herein it involves administration of local anesthesia and isolation of the tooth. Proper access opening should be done. The entire coronal pulp chamber should be extirpated. Any pulpal debris should be flushed out by the means of irrigating solutions. Then proper biomechanical preparation of the canals should be done after location of the canal, and the irrigation should be done. The biomechanical preparation of the canal should be done, and finally the canal should be obturated by the means of a resorbable material like Metapex or Vitapex or zinc oxide eugenol, which are used for obturation. That means in the range of closed apex obturation is done, and in open apex only calcium hydroxide or the material which induce cementum and dentine formation like Metapex or MTA should be followed. Here we can see the pictorial representation of the same, the coronal chamber being removed, the biomechanical preparation being done, and finally obturation is done by a resorbable material. Now if the apex are open, then we go for apexification procedure. And also apex which are open are known as blunderbuss canals. That is, they are shaped by the like a blunderbuss, or they can also be parallel. So the dentine will be very thin. The biomechanical procedure in such teeth should be limited. It can be divided into a single appointment or a 2-appointment procedure. And the main aim should be obtaining a good apical seal so that a foreign or the obturating material should be pressed against the apical seal for maintenance of the hermetic seal to prevent any contamination of the pulp from the external periodontal tissues or contamination of the periodontal tissues from the pulp. So the root is very thin and fragile in such cases, and it should be taken into consideration. An apexification can either be a single sitting procedure or a double sitting procedure. In a single sitting procedure, we directly place calcium hydroxide and obturate by the means of obturating material. In double sitting procedure, we place MTA or mineral trioxide aggregate, and on the second appointment, that is after 24 hours, we obturate by the means of gutta perchas. Now, coming over one of the most complicated types of traumatic injury, that is avulsion. Avulsion is also known as exarticulation or the loss of teeth from the oral cavity. The chances of avulsion injury is about 0.5 to 0.16% in permanent, whereas 7 to 16% in primary tooth. This is because the alveolar bone is more spongy and resilient in primary tissue, which will lead to the increased incidence of avulsion in primary tooth. Then the etiology of avulsion is due to any fall from a bicycle, or any fall from a car, or any fall from a high place, or fall against a stable object, which will lead to a resilient injury. Further, leading to avulsion. So, on examining, or if a patient came with the avulsion tooth in the dental clinic, we have to examine the tooth as well as the dental socket and the entire oral cavity, whether any injury is there to the soft tissues or the supporting tissues of other teeth as well. So the avulsed teeth as well as the socket is examined. This is one of the most important procedure. The history of the avulsed tooth, that is how the injury took place, should be kept in mind. Even the medical history or the background of the patient should be recorded. So the teeth should be examined, whether any debris or calculus or any foreign bodies are attached to the tooth. The tooth should be rinsed properly and should be kept in a proper storage media immediately as the patient arrives with the avulsed tooth in the dental clinic. But there are various considerations on which the treatment plan will depend, whether if the avulsed tooth is not related to any pathosis or pathology of any kind. Otherwise, the prognosis of re-implantation of the avulsed tooth will be very poor. The condition of the alveolar socket, whether it is comminuted or the walls are intact. Even the extra alveolar time which the tooth involves from bringing it from the fracture site to the dental clinic, whether it is 5 minutes, 10 minutes, 1 hour, 120 minutes or greater than 24 hours also. So all these factors should be considered before planning the treatment for a avulsed tooth. Now reimplantation is decided, which is the treatment of choice in the same. Before reimplantation, tetanus prophylaxis is very important. Even the patient can be kept under antibiotic coverage to prevent any further bacterial infections. The root surface should be washed with the saline. It can also be treated by sodium fluoride solution so that the surface becomes reinforced. Then the alveolus is rinsed by the means of a saline without disturbing the periodontal tissues or disturbing or scraping out the alveolar socket. This will prevent any hindrance from reimplantation. Then the tooth can be reimplanted by them holding it properly, first rinsing the tooth, then placing it with a means of digital pressure inside the socket apically, and the treatment and the forcing of the tooth should be very minimal pressure involved. Then we'll ask the patient to bite on a gauze piece, further repositioning the tooth in the socket. Then a flexible splint should be applied immediately to the tooth for stabilization of the tooth, and the patient should be recalled after 7 to 10 days. It should be kept in mind that the patient should be given instruction to take only soft diet during the entire treatment procedure, even after going back home, and brushing with the help of soft toothbrushes and oral mouth rinse should be prescribed. Now there's various type of reimplantation, that is immediate reimplantation and delayed reimplantation. Immediate reimplantation is done in the cases where the on the spot, if the tooth is brought to the dental office immediately or within the lifespan of 60 minutes. So it will depend. For example, if on the spot or immediately after the injury the tooth is brought to the dental clinic in the media, then we can reimplant it immediately. But if the tooth is brought from 5 minutes to 60 minutes in either in saliva or in water, then we go for treatment of the tooth by putting it in Hans balance salt solution for 5 to 10 minutes. Then treating the teeth with doxycycline for 5 minutes or by rinsing it with 1000 ml of saline, then reimplanting the tooth in the oral cavity. And if the extra oral dry time of the tooth is greater than 60 minutes or 24 hours, then the tooth has to be treated by sodium citric acid followed by sodium fluoride treatment and then reimplanting and splinting of the tooth. Final splinting and final root canal treatment should be done after final splinting, that is 7 to 10 days when the tooth has stabilized in the arch. Various medias which are helping in storing the teeth in extraoral time is Hank's Balance Salt Solution, which is HBSS. It is one of the most potent media for storing tooth outside the oral cavity. Even milk is considered as a potent media. The vestibule of the mouth of the patient or saliva, and the least recommended media is water because it's not a biological media. It may lead to drying of the tooth or loss of vitality of the tooth. Then reimplantation is done as I've already told before. The stabilization is accomplished for a period of 10 to 14 days and then RCT is done. Now delayed reimplantation is done if the extraoral the time of the tooth is greater than 24 hours and the root of the apex of the tooth is not complete. Then we perform a root canal therapy outside the oral cavity and the apical two-third of the root is cut, 2 to 3 millimeter is cut, and the root is obturated retrogradely by the means of gutta percha point. Then it is further reimplanted in the socket and final fixing and stabilization is done by the means of splints. Now, there are certain complications in the means of delayed reimplantation. It can be either cemental reabsorption or internal resorption of the tooth. Now, coming over to the root fractures. The root fractures involve dentine, cementum, and pulp. Either permanent dentation or primary dentation, both can be involved in the root fracture. It can be either single, multiple, complete or incomplete type of root fractures. The main etiology of such type of fractures are a blunt injury or falling against a stable object or the foreign bodies which is striking against the tooth. Then clinical and radiographic examinations need to be done for the fracture of the root. If the radiograph is taken by the means of bisecting angle technique at 15 to 20 degree angulation of the X-ray over the tooth, then only the root fracture can be visible. On clinical examination of the tooth will appear to be slightly occluded out of the socket and displaced lingually. Now, the treatment of the root fracture will depend on the level of the root fracture, whether it is apical or in the middle third or in the cervical third. The cervical third type of root fractures have the poorest prognosis. If the coronal fragment is separate, it should be extracted because it has a poor prognosis. And then an apical third of the root can be left over as such if slight apical portion is fractured. Then in the middle third, the tooth needs to be root canal treated. If the resistance is felt during slight repositioning of the tooth, then immobilization of the root by the means of a rigid splint should be done. There are various types of splints like arch-wise splints, the bar type of splints, and acrylic splints or even suet appliance which are used for splinting the root or the avulse tooth in the oral cavity. A splinted root should be kept for a minimum of 1 year follow-up and 2 to 3 months of splinting should be done to ensure complete stabilization of the tooth. Now, if there is a root fracture in the primary tooth, it needs to be basically extracted, but the time period or the lapse of the tooth in the oral cavity should be kept in consideration. For example, if apical fragment is broken, then the tooth can be left as such in the oral cavity and splinting can be omitted. But it should be taken care. The tooth should not be scrubbed or the root surface should be left as such without mishandling of the crown or the root. Now there are various types of injuries like subluxation or the injuries to the periodontal ligament or concussion. For example, in primary teeth, if the tooth is slightly subluxated, the tooth should be left as such in the oral cavity and waiting for its recovering on its own. And if there is a case of concussion injury or a subluxation injury, or if its tooth is displaced lingually, then repositioning of the tooth can be considered. But if the tooth is placed buccally, it should be extracted because it can cause harm on the permanent tooth buds which are present. If the tooth is extraculated or if the tooth is slightly extruded from the socket, then repositioning of the tooth should be done without causing damage to the permanent tooth bud inside. Sometimes extraction is the treatment of choice in such cases. Now, apical barrier technique is a technique for apexification in which a tricalcium phosphate mixture with the collagen chloride is placed at the end of the root and it is mixed with saline. Even mineral trioxide aggregate is placed as an apical barrier on the end of the root, and then finally gutta percha is packed in the same visit. Some other materials which are used for the apical barrier technique are freeze-dried bone, the bioceramic glass MTA and the hydroxyapatite. The various criteria for the success of apexification is complete root development, any absence of pain, mobility or fistula, and any absence of radiographic signs of any pathological resorption or any pathological abscess. So finally, traumatic injuries are one of the major causes of trauma or loss of tooth structure or any harm to tooth structure, and they should be avoided in children and prevented in children. Thank you.